Well, good morning. Howdy. Nice to see everybody. Looks like I am having a difficult time getting one of our video feeds to work here because it's always something, isn't it? But top of the morning, CNY Nation. I'm Dr. Randy Fink, and I am sitting in for the good Dr. Robert Kiltz this morning. Dr. Kiltz normally does your fertile fireside chats, and I am very happy to be here on his behalf today, as I am still trying to get the Instagram feed for the CNY side to start, but it looks like that one just doesn't want to work for us here. So I think we may have to do without the CNY side. But I am live from beautiful Colorado Springs here this morning. Normally, my chats are on Tuesday afternoons at 4 o'clock Eastern time, but gosh, it's an early morning. Well, it's not that early, but a few minutes after 8 o'clock on the mountain time, which means about 10 o'clock, a little after 10 o'clock on the East Coast. Sure, I'm glad to have everybody today, and good to see. Hi, Nelson, and hi, CC Journey. Can't wait to start your journey with you in come August. And I see some of my friends here. Oh, Baby Wise has joined us, and good morning from Los Angeles. Hi, Andre. I saw my friends in Miami, William, and his beautiful, lovely wife. So let's see. Well, we're certainly available for all your questions here this morning. It's kind of bright. It's a beautiful, bright Sunday morning in Colorado Springs. It's about 33 degrees is what we have here, which is not unusual. We had a goodly amount of snow yesterday. Oh, gosh. CC, a.k.a. Pinky, good morning from the Bahamas. Happy to have you. And Llama Single Mama, we're happy to see you as well. So we had about up here on the mountain near my house, I would say close to probably 5-6 inches of snow. The day before, it was about 74 degrees. And so that is your Rocky Mountain springtime here. I think last year on Memorial Day, I think we got a major big dumping of I think a foot of snow, the first day before June. So things can get kind of crazy, but that's part of the beauty of it all. And part of the beauty of the whole process here of being with you is being able to talk about things that are important to you, have a cup of coffee together. I don't even know with the sun behind me that you can see the fire there, but it is a fireside chat. So Wisconsin scheduled to get 9 to 12 inches of snow tonight. Boy, that is just crazy. Hey, Andre's asking, we had four had a level, well, let's see, immune protocol 3 and still no luck. Had 4 pregnancy losses. So let's talk about that pregnancy loss thing, because it is such a frustrating process to have to go through, and especially when you've done everything right as far as the IVF to make your embryos, and then you place an embryo back and things don't work. There's a couple of different possibilities and things that we ask about. First of all, when these things aren't working, is it because we're putting embryos back in that aren't sticking? Or is it because we are putting embryos in and pregnancies are happening and then the pregnancies are stopping? So a couple of different types of scenario there. And before we get to that, say hello to Amber. Happy Sunday. And away Paige goes. Good to see all my friends here on Sunday who are like, what are you doing here on a Sunday? Erica, good morning on the Facebook side. Unfortunately, I guess we're missing our CNY Instagram feed here because the computer doesn't want to connect, or at the last minute it didn't want to do there. So if you know anybody who wants to watch, we're on my Instagram, Dr. Randy Fink, or rather Randy Fink MD, and LinkedIn and Facebook this morning. So when we're talking about pregnancies not working after transfer, the first thing that I generally think about is whether this is an embryo issue, because most commonly the embryo is the bigger issue, more so than the mom. So, but there is a pretty standard workup that we look for when things aren't working right. The first thing I start to think about is, well, when was the last time the uterine cavity was evaluated? And so we're looking for either a saline sonogram or a hysteroscopy, because we want to know that there's no polyps, that there's no fibroids, that there's no bands of muscle, that there's nothing mechanical inside the uterus that is stopping that lining from working. The second thing we usually ask about, so the classic wisdom was laparoscopy, hysteroscopy. So the laparoscopy is designed to see if you have endometriosis. And endometriosis is a situation where the lining of the uterus that normally would slough off when you have a period, instead of sloughing off, works its way up to the inside of the pelvis. And when it does that, it can stand in the way, it can interfere with the way the brain is talking to the uterus. So think about, lines of electricity, power lines. Well, it's not that somebody cuts the line, but somebody diverts the line, or somebody changes the electricity that's going through between brain and uterus, and can affect the way the uterus will implant. And that's a problem. So the classic way to diagnose that was with the laparoscopy. And the laparoscopic surgery is where we place a little camera inside the abdominal cavity through the belly button under general anesthesia, and we're able to take a look around and see kind of what's going on. If there's endometriosis, we can treat it. There is a non-invasive way to examine for endometriosis, and that's a test that's called Receptiva. Receptiva is an endometrial biopsy that's done at a particular time of the cycle, where we take a little sample of that uterine lining and check it for the presence of a protein that's called BCL6. And what BCL6 does is that it's a marker of inflammation that is associated with endometriosis. And in the presence of BCL6, it will decrease the probability of a pregnancy implanting down to below about 12%. So if we find that issue, then what we want to do is to treat the endometriosis. And so there's medication that we can use, and I'm trying to get myself out of the sun to see if you can see me a little better here. When we use that medication for a minimum of 60 days, we can alter the success rate of the embryo transfer from about 12% to up to 60%. So that's a good reason to do that. Certainly, folks who are having recurrent pregnancy loss, we want to look in mom's blood to see if there is any kind of issue in mom's blood that may be keeping people from implanting. And that's a panel that we call the recurrent pregnancy loss panel, which looks for something that's called a thrombophilia. And what that means, thrombo means clot, philia means likes to. If there's something about mom's blood that makes it like to clot, then you can form little blood clots in the tiny blood vessels that are supplying the uterus and the placenta. And that's a problem as well. Now, typically we treat for those anyway, and that's what the Lovenox, the blood thinner, is really for in our immune protocols. But the other thing we think about is, well, how can we maybe be able to help with the embryos. And that's where the PGT testing comes in, because when we have a tested normal embryo, then we know that there is about a 60% probability of a pregnancy, and a little above a 50% probability of an ongoing pregnancy when we know those chromosomes are normal. So it's not a perfect test, that PGT, and we can talk some more about that if folks have questions about PGT. But we will certainly keep our fingers crossed for you and hope for the best. I will say that increasing the immune protocol is something that we can absolutely do, because in case there is an issue with mom's immune system that's trying to treat these embryos as invaders, then we can certainly try to suppress that. Good morning to Brandis, who is here with us, and Indy Scorza saying, got the first positive pregnancy test on Friday after 4 years of trying to conceive. Oh my heavens, we are over the moon for you, my friend. That is absolutely fantastic. And I know that everybody else who's with us today shares in that joy and can't wait to experience it for themselves. Sally is with us, and I believe Sally, if I am not incorrect, is in the Caribbean. Sally, welcome to the Facebook side, and good morning. Sally can't wait for Sarasota to start doing IVF, and we are told that is going to happen this summer. So Sally's asking, is it best to use Crenone progesterone or progesterone in oil injection during that first 10 weeks of pregnancy? It's a very good question, to which I toast you with a cup of with a latte. So what's the reason for that progesterone anyway? And if you see some movement behind me, it's my dog Lulu, who is she's creeping around here. I wouldn't be surprised if she tries to come up and get on my lap, which would make me very happy, because that's a good thing. Norma Jeans, oh hi! Wow, what a treat to have you with us in South Florida. So we're talking about progesterone. Why you need progesterone anyway? Well, in a natural pregnancy, your ovary releases the egg. That egg hangs out and waits to get fertilized. Sperm comes along and fertilizes it. And then that creates your embryo. That transaction happens inside the fallopian tube. And once it's happened, the embryo floats its way down the fallopian tube and implants in the uterine lining. When the ovary releases its egg, it leaves behind a space, and the cells in that space start creating progesterone. And it's that progesterone that makes the pregnancy continue. Progesterone is what that hormone does. It organizes the uterine lining and creates a space that's hospitable for a pregnancy to grow. And I like to think of that as your baby blanket. It makes that baby blanket inside of you so that the embryo can be inside the uterus and grow successfully. Well, in IVF, since we haven't generally had the ovary release an egg to make progesterone, we give you the extra progesterone. And with IVF, you need a lot of progesterone, because the progesterone that we're giving you is never quite the same as the natural progesterone. Now, you still do have some natural progesterone, but we need to give you more. The progesterone gets secreted by that portion of the ovary, which at that point is called a corpus luteum, if you're familiar with that expression. The corpus luteum makes your progesterone until about 9 weeks of pregnancy, at which point the placenta takes over. And once the placenta takes over, that's where the progesterone comes from. So we need to give you some extra progesterone until the point where the placenta starts to do its own thing. And the data shows us that cursed PIO shot, the pregnancy in oil, the progesterone in oil shot is the best way to get that progesterone. The outcomes are better in pregnancy if there is when using the progesterone in oil. Now, we supplement that as well. We supplement it because you just need more. So progesterone in oil is going all throughout your system, whereas the vaginal progesterone, which comes in one of generally 3 different forms. Crinone is one commercially available product. Endometrin is another commercially available progesterone cream. And the third one is sometimes we can use just a micronized progesterone pill, which is placed vaginally. And what that does is that it creates a local effect of the progesterone. So if you're just using the local progesterone and not the systemic progesterone, the outcomes are not going to be as good. If you're using the progesterone in oil, it is better. Now, I have a preference for endometrin over anything else. I think endometrin works better than the micronized progesterone pills, which are designed to be taken orally, but we use them vaginally, and so it's fine if you would like to. Crinone, I find, increases the risk and the odds of having vaginal bleeding in that first trimester. And there is nothing that freaks out an early pregnant person than bleeding in the first trimester. And 50% of normal pregnancies have cramping and bleeding in the first trimester. So it's not an unusual thing to happen, but that odds of that bleeding are a little bit higher, I find, in my experience with Crinone. So PIO is recommended, and hopefully that'll help there. Hey, just a quick comment there to Facing Destiny. Hi, nice to see you this morning. You did send that request for the supplement list, and I got sidetracked during the week and did not get to those. I will do those today. And what we're talking about there is that we have created the kind of curated list of the supplements that are recommended from the book. It Starts with the Egg, which is really a great book. If you haven't read it, you should take a look at it. It's pretty interesting. But we've also done it for you and found the correct list for all the different reasons, whether it's egg quality or just IVF or IUI or trying at home. In general, what we can do to improve egg quality, sometimes sperm issues, also so male factor and diminished ovarian reserve. There is a list specifically for transplants. We've created that list, found the right formats of those medications, or rather those supplements, found the correct dosages of those, and what we believe are the least expensive or the fairest or the best prices for the amount that you can get. And we put them on a list just to make things easy for you. So all you kind of have to do is click a button. And so you can, best way to get that from me, if you have a consult with one of us, then myself or Brandis, then we will certainly send you that list. And often there's a little discount code on it. But otherwise, Instagram me, and that is Randy Fink MD, and I'm happy to send you the link for that list. And again, my apologies there, Destiny. I promise I will do that today, because the sooner that you can get on that stuff, the better. I absolutely 100% believe that supplements can make a difference in the biochemistry of egg quality and of implantation. So really strongly encourage you to follow the guide. That book is extremely well researched. The book is It Starts with the Egg. Half the book is the bibliography. If you want to kind of look at the studies and see, what it's all about, then, but we've done the work for you. So all you have to do is let us know. And I promise we will cooperate for sure. If you're just joining, I apologize to those folks on the CNY Instagram side, but couldn't get that one to connect here this morning. We've got my Instagram, we've got the CNY Facebook, and YouTube and LinkedIn for Fink's Fireside Fertility Fireside with Fink, Fireside Fertility, Fireside Fink, triple F. Dr. Kiltz is away this morning and asked me if I wouldn't mind to sit in, and it is always my pleasure. I'm usually here on Tuesday afternoons at 4:00 Mountain Time, so please join me then as well. Vilma on the Facebook side is asking, why do we need letrozole during a modified natural FET, and why isn't HCG trigger not enough? Well, Vilma, you ask an excellent question. Personally speaking, there's a couple different types of natural cycle embryo transfers. So the first is what we'll just call a natural cycle. And in a natural cycle, you don't have to do anything at all because your ovary will create an egg unless you don't ovulate. If you are somebody who doesn't release an egg on their own, then we will give you letrozole as ovulation induction in order to get you to release that egg. If you're not an egg releaser, we got to get you to release an egg. Otherwise, there's no sense in doing a natural cycle because nothing is going to happen. In the natural cycle, your ovary makes that follicle. You grow that follicle until it's mature. In a completely natural cycle, we'll just let you ovulate it. We'll let you release it on your own. And when you ovulate that egg, that starts the clock ticking for when you will have your embryo transfer. Okay, well, that's a nice, easy way to do it. The problem is that it leaves some of the logistics, to the wind. And so since people have to travel to get to us to our different locations, be it in Colorado Springs or in upstate New York, we can trigger the ovulation, which gives us some control over the logistics of the timing. And so that's really the reason to use the trigger. We can use HCG. That's a pretty easy way to do it. We can use Ovidril, which is a synthetic form of HCG. We can use Lupron. So lots of different options for trigger. So the other thing we can do is a modified natural cycle. And in a modified natural cycle, well, we give you letrozole to make sure that you're going to release an egg. In my opinion, I personally don't like using letrozole for that indication. If you have normal periods, then you're going to release that egg on your own. So giving you letrozole is really just going to affect the way it's going to have an effect on your estrogen levels, which ultimately can have some effect on the lining and potentially the ongoing pregnancy. So I do not use letrozole for natural FET cycles unless you don't ovulate on your own. And if you're an anovulatory person, then it's not so much a natural cycle FET as it is a modified natural cycle FET, where we're going to give you letrozole, some medication to make sure that your ovary releases an egg. So hopefully that, and of course I remembered you're from Trinidad because I have friends in Trinidad. So I moved to Colorado from Miami, and our thoughts go out to all our friends down in South Florida who got the great deluge. I think there was something like 25 inches of rain in 6 or 7 hours, which is really just a crazy thing. It definitely gets, thunderstormy in the summertime with some real torrential, tropical downpours, but that's a lot of rain to have. I think the Fort Lauderdale airport, it took a few days for it to open back up there. So, so let's see what else we have here. Welcome. Good morning, Miranda. If planning to do a reciprocal IVF with my wife, should we both be on prenatal vitamins and the other vitamins? So reciprocal IVF, honestly, I think is one of the coolest things that we can do. And that's where we take eggs from one female partner, we create embryos with donor sperm, and we place those embryos back into the other female partner so that both partners in that female couple are participating in the pregnancy. And if they're, I think that is honestly just one of the coolest things imaginable. So good luck to you guys. It's really fabulous. So should you both be on the supplements? Well, there is a list of supplements that I recommend specifically for egg quality. And that's what I was talking about from the book. It starts with the egg. We can send you that list of supplements. CNY also has some wonderful supplements from a company called Molecular Fertility that are on the CNY website. But we'll give you the curated list. Those are the supplements specifically for egg quality and for IVF. There is a separate list that goes along with to the person who is going to be the going to be the recipient or in whom we're going to do the embryo transfer. Now, there's definitely overlap in those. The prenatal vitamin is one thing. Some fish oil, DHA is one thing. But in the embryo transfer group, there's specifically some vitamin E and some vitamin C and some L-arginine. And so whereas for egg quality, there are a few other things on that list. So a couple of different things depending on which side of that reciprocal IVF you're going to do. Let's see here. It looks like Clara. Oh, you know what? I'm forgetting to answer my friends here on Instagram. I'll go that way in just a second. It's just because the Facebook side's right in front of my face here. Clara says, I received my Lupron trigger last night. I was told not to refrigerate by the pharmacy, but my nurse said to refrigerate. I don't think Lupron needs to be refrigerated. I would say if the pharmacy told you it does not need to be refrigerated, the buck stops with the pharmacy. They're responsible for that med from the time it leaves them until the time it goes into you. And so if their instruction was that it did not need to be refrigerated, I do think that you're fine with that. I will tell you, a lot of the meds will come refrigerated just because they are more and Brandis is answering, I see on this side here, unless it's pre-mixed. Not sure what that means, but I didn't do an egg freezing cycle myself. So only if it's mixed. Okay, I'm getting this from William. Only if it's mixed, but not normally. So a lot of times these meds will come to you refrigerated because it's more stable when it is when it's shipped. And you know, if it's shipped and you don't know if it's going to sit in the bottom of an airplane or sit out on a tarmac, pre-mixed needs to be refrigerated. But if it's already mixed, then it does not. And that seems to be the definitive answer, Clara. And I hope that helps. But as I was saying, a lot of times these things will come pre-mixed, or rather will come on ice just so that it will protect its stability during shipping, but that once it's at your house, it doesn't need to be. But hopefully we just answered that one. And yes, my pleasure. All right, let's see what else we have here on the Instagram side. I see from Blonde Babe 27. Good morning. Nice to see. If my cycle is unpredictable a lot, is a modified transfer the best thing to do? And I would say yes, because what's happening there is that your cycle is kind of based on when you ovulate. And so usually what happens is that there's some variability in the first part of the cycle. In the first 2 weeks, in somebody who has a 28-day cycle, the first half of the cycle is called the follicular phase, and that's when you're developing your follicle. Then you ovulate, then you release that follicle, and once that follicle is released, then it becomes the luteal phase. So there's often some variability, and you remember why it's called the luteal phase? Because that area that's left behind is called the corpus luteum, right? And that's what makes the progesterone that we were talking about before. Well, there's some variability in the follicular phase, but in most people, there's a fair amount of consistency on the luteal phase. Usually, it's about 14 days from the time you ovulate until the time you get your period. But the follicular phase can be quite variable. So in women who have irregular periods, you know, you may have a 30, 60, 45, 15, 21, really quite variable in the time it takes you to ovulate. But once you ovulate, once you do release that egg, then you have 14 days until the time you get your period. So I think, Blonde Babe, what's probably happening there is that you have a really variable follicular portion of the cycle. And so that is the right indication for a modified natural FET if you're going to be doing a natural cycle. And that's because you're not ovulating with predictability in terms of the timing. So if we give you some letrozole for 5 days, letrozole tells the brain to tell the ovary to make a follicle. So that means that we know that we will make a follicle that's going to get you an egg to ovulate so that your cycle will proceed in as normal a fashion as it would if it were just a completely natural cycle. So that's the indication specifically for the letrozole. So good luck to you there, my friend. Let's see what we had here. I believe we had a couple of other questions on the Instagram side. It looks like Kielane. I know I'm pronouncing that name wrong, so please forgive me. Kaya. I'm so sorry. Is age a factor of why lining takes longer to thicken? I've been on estradiol for a week and it wasn't thick enough. So what she's asking about is what happens with that uterine lining, and why is it that why do we care? Well, the lining, as I said, becomes your baby blanket. So we want it to be a minimum of about 7 millimeters in size by the time you start your progesterone. And that portion, that's what we call the progesterone start time. 7 millimeters is what we're looking at because that makes it a thick enough baby blanket to keep your embryo warm. Think about it that way. Age can definitely be a factor as to why it gets harder and harder in some people for that lining to get thickened. Certainly folks who have had procedures done inside the uterine cavity can have issues with the lining getting thicker, but it is certainly more common that it just happens without any good explanation in women who are more mature. So and that's honestly one of the most frustrating problems in cycling folks for an embryo transfer that we see is getting the lining thick enough when it's not responding the way it's supposed to be. So when we're doing a medicated cycle, and we're giving you estrogen and your lining is not thickening, well, then we start thinking about, well, gosh, do we need to be increasing the estrogen level? Maybe the receptors are just not working right, so we need more estrogen to get things to respond. So that's one way to do it. We'll often add some vaginal estrogen as well, so that you're getting it both systemically, coming through the pills that you take by mouth, and vaginally, where it can have a local effect on that uterine lining. There's an injectable form of estrogen called del-estrogen that typically will work very, very well. It's something that you get an injection of every other day. It's not super expensive, but it's something that we do when the normal way we do things isn't working right. We can use Viagra in a woman because it increases blood flow to the uterus and is pretty well studied. So that's another option there as well. But to answer your question, yeah, age can definitely be a factor. But certainly if there's ever been an injury to the endometrium, that's something that happens as well. And we see that, pretty commonly in folks of any age. Good morning to Brandy Pruitt Russo on the Facebook side. My CNY Miracle baby, oh my goodness, is 2 weeks old today. Forever indebted. Gosh, Brandy, that is just fantastic. A 2-week-old baby. I am sure that you are sleeping very well at night, aren't you? And very relaxed during the day. Gosh, what fantastic. Wonderful news. And to all those who are not quite there yet, our thoughts and prayers are with everybody. And that's why I 100% of the time encourage anybody that we're doing an embryo transfer on to record that transfer. So in Colorado, we've got a monitor that's up on the ceiling. So you just have to point your phone up at the ceiling so you can see that little flash, that you can see how amazing that moment was when you got pregnant. Because when that baby is born and they first put that baby on your chest and you look at your baby for the first time, it's really magnanimous to then be able to go back and look and see a picture of an embryo from the laboratory and to see the moment that embryo made it inside your uterine cavity. So, oh my gosh, Brandy, we're so happy for you and congratulations. Des is here with us this morning. Hi, it's nice to see you on the Facebook side. did protocols change yet for the HCG wash? Some kind of drugs to knock you out for that pain? If so, can I also get that for the Receptiva test because that test hurts? Well, so again, what we're doing with Receptiva is that we're placing a straw inside the uterine cavity and sucking out a piece of tissue. So, yeah, that's not the most comfortable thing. In fact, I'd have to say in general gynecology, the endometrial biopsy is my least favorite thing to have to do to people because, it's not all that comfortable. Is it? Now, there's some skill to it. There's some nuance to it. There's some finesse to it that can help to make it gentler. But at the end of the day, you can have some finesse if you smash your head against the wall, but you're still smashing your head against the wall. So it's going to not feel good. One of the potential solutions to that we're working on with Dr. Kiltz is hopefully to be able to have some laughing gas in our clinics. Laughing gas is nitrous oxide, and it's something that you can simply breathe in. It helps you to relax. It takes away the anxiety. And it, as you probably know from dentistry, where laughing gas is a very commonly used thing to help alleviate the anxiety of people doing things, in your mouth. The reason that we haven't jumped on it, and I had talked about laughing gas or nitrous oxide before on my Tuesday afternoon live, is, we want to make sure, from a patient safety standpoint, it's a very, very safe thing to use. It's what's called a demand system. So you're breathing it yourself. If you reach the point where you're relaxed enough that you can't breathe it anymore, the thing kind of falls out of your mouth, and 2 minutes later, it's gone. But nitrous oxide can be toxic to embryos. And so what our research is really focusing on now is to make sure that there is not nitrous oxide in the atmosphere released into the air, really, that could float its way to the embryology lab and affect our embryos. We believe the answer to that is no. It is not something that needs to happen, but that will be a wonderful addition for things like the endometrial biopsies, for the HSG especially, and for the more painful kinds of procedures. So my hope would be, Dessa, that the HCG wash should not be a procedure that's full of torture. And what we do there, it's a very thin straw. It's a transfer catheter that we place inside the uterine cavity and place about a teaspoon of fluid inside. And that may be something that you feel, but hopefully is not something that causes a great amount of pain. So let's see what else we have here. It looks like this is coming from Shanae, who says, I'm almost 39. I have a low AMH of 0.2. Shanae has one ovary. Am I chasing a dream to do trying IVF with my own eggs? I do ovulate with regular cycles. I have eggs, although a few, and I do make embryos, just not very many, 1 to 3 per cycle that make it to day 3. I just finished cycle number 7 with CNY. For baby number 2, my first baby is a CNY miracle after 6 cycles, but not pregnant yet this time. Shanae is thinking about being at a crossroads. Do I keep trying or do I throw in the towel? Well, it's a very individualized decision. So with the lower AMH, the anti-Mullerian hormone, which is our test of ovarian reserve, it tells me that you're not going to have a robust response to the medications. So it means we're going to be limited in the number. I suspect it's also going to mean we're going to be limited in the type of egg quality that we have. So it's an uphill battle with the situation that you described. Now, it took you 6 cycles to get baby number 1, but it worked. So the truth is, probably, eventually, it's going to work for you. So if you just keep doing it, eventually, you're probably going to get what you want. The question is, How much of it can you afford financially? How much of it can you afford emotionally and mentally? Because yeah, the science, if you play the numbers, it probably will eventually do what it's supposed to do. But it's such an uphill battle. How long is it going to take you to get to the top of the hill? And is that something that you can tolerate? Now, the other option there is also to think about either doing a donor egg or a donor egg backup. With a donor egg backup, you can take an egg that you purchase from a donor, and while we are fertilizing your eggs, we can also fertilize the donor egg, so that one way or the other, as we come out of that cycle, we will have embryos that you are able to transfer. That have a high probability of being able to get you pregnant. Many people, I've talked about this before, and I think it's definitely worth mentioning here again. And that's a topic that's called epigenetics, because I think, one of the most common things that I hear when we start having the conversation about donor eggs is this idea that, well, nobody really, most people don't go into IVF with the hope of having to do donor eggs. We would certainly all prefer to be able to use our own genetic material if we can, but sometimes we can't. And so one of the most common things that I hear about is, well, I don't want to have somebody else's baby. I want my own baby. Every drop of blood that flows through that baby inside of you, irrespective of where the egg came from, every drop of blood is yours. There is no question when that baby comes out, it's your baby. Well, the thing that even furthers that now is this topic of epigenetics. So there's a million different switches that can be on or off in any order. Imagine whatever permutation you can think of. These switches can be on and off, and they are determined by the environment in which the embryo grows, i.e., your uterus. So those switches are what control all the different factors about the baby. Yes, the eye color is going to be determined genetically, but everything else, personality-wise, I won't say everything else, genetic diseases that were carried and so forth, that's all in the chromosomes. But will that child be, I always say, artistic or mechanical? Will that child have a great sense of humor or be quiet and shy? Will that child like to color with crayons or markers? Those things are all related to the environment where the embryo grows, your uterus. That's epigenetics. And so not only is every drop of blood going through that baby yours, but so many of the determining factors of how that child is the patterns of behavior and how that child will grow come from your uterus. So epigenetics now even tells us that more so than we ever thought before, that embryo from the donor egg is yours. So it's not something to fear. And if you'd like more information really on what that even entails, how do you pick a donor? What are the costs? Well, I always know that the costs at CNY are going to be a fraction of what they are any place else in the country, but reach out to our donor team. There's no harm in asking for the information. They're just going to send you a packet through your portal or through the email. Just email through the portal if you're a CNY patient to a donor coordinator and get the package of information. Read about it, because all it's going to do is give you information. And information is always a good thing. Whether you act on it or not, well, you can decide. Maybe it's the right time, maybe it isn't, but at least you'll have the info. Anna's asking, how long after stopping birth control will your cycle come? Well, so when you're on birth control, you're getting both estrogen and progesterone. And so typically what happens when you stop your birth control pill, within a few days, you will start to get a period. And that's what we call a withdrawal bleed. Because you have a hormone level, you take it away, that hormone level drops, you're withdrawing the hormone, and that precipitates the period. That's mimicking what's happening in the level of the hormones in the ovaries. So it should be just a few days. Now, in some birth control pills, especially with the very lower dose pills, the lining of the uterus will thin out so much, it will atrophy to the point where people just may not get periods. And so, in general gynecology, I think that's a great thing. If your period is a day of spotting, or even less than that, maybe it's just a little, kink of something that gives you a clue, or maybe even nothing at all. And that's just fine. It's not harmful in any way. It's certainly better than, 5 or 7 days of having to, buy and use a bunch of products and go through cramps and clots and everything else. That's one of the ways, that's one of the mechanisms by which birth control functions to keep you from getting pregnant, by thinning out that lining so that sperm can't swim. Oh, you like that visual there? Yeah. So that sperm can't swim around on the inside. That's probably the better visual. There you go. You're welcome for that. And that's going to help your Sunday, no question. So typically within a few days, unless the lining is atrophied, in which case it may take a little longer for it to actually grow back for you to slough something off. Now at CNY, we will use birth control for a couple of different reasons. Sometimes we will stop and have a drink of coffee. Sometimes we'll use birth control to help you coordinate when your cycle can happen. There are many clinics in the United States that use birth control pills to batch their cycles. And that is, I've mentioned before that most IVF clinics will do anywhere from call it an average of about 150 cycles of IVF per year. 150, maybe 200. That's a busy clinic. But of course, that's at $30,000 or so per cycle. At CNY, we are doing sometimes even 20,000 cycles a year between our different offices, anywhere from 10 to 20,000. A big difference in terms of the number of cycles. So we're doing egg retrievals, fertilizations, embryo transfers every day of the week except for Sunday, which is the time at which all our offices are closed. So if you're batching cycles, it's so that your embryologist only has to be there for 1 or 2 weeks a month, so that your anesthesiologist only has to be there 1 or 2 weeks a month, and you can use a couple of weeks for monitoring and 1 week for retrieval and 1 week for transfers, and that just makes their workflow easier. We don't need to do that because of the volume of patients we're able to take care of. So that's why we don't batch our cycles. But sometimes we'll use birth control, or even just some estrogen and progesterone alone. Estrase and prometrium typically was what we'll use in order to simply help to synchronize the eggs in your ovaries. If you've been through IVF, you may know that you'll have a 20 millimeter follicle, an 18, 2 17s, a 16, a 14, a 12, and a couple of 8s. Well, those are follicles that are out of sync. Didn't grow at the same rate. They didn't grow together. Sometimes using even just 14 to 21 days of estrogen in particular, but estrogen and progesterone in the form of a birth control pill makes it very easy to synchronize those follicles and help them to grow at the same pace. So we may use it for that too. So hopefully that helped you there, Anna Maria. Let's see. Let us not ignore our friends on the Instagram side. Do I recommend a duostem if we are only producing 3 eggs or less? 36 years young with diminished ovarian reserve. Duostem is where we do a retrieval and we start the next stimulation within a few days, 3 to 5 days typically. I usually don't recommend a duostem in that situation. What I recommend personally is a back-to-back cycle. So it's about 10 days, you get a period, and then with your very next period, you start another stimulation. So 100% in that scenario. And in fact, in really every scenario, the data shows us that when the medication that you use in 1 month is going to continue to help you in the next month. The duostem was originally designed for really women who have cancer, who have to start some kind of treatment, who have a hard stop date because that's when they're starting their chemotherapy, for instance. So we need to get every ounce of egg recruitment and retrieval that we can before some fixed date. Then we'll do a duostem. That's what that was designed for. Duostem, in my experience, and based on some of the data, can decrease the number of eggs that we retrieve. So whereas a back-to-back is uniformly and not controversially known to increase both the egg quality and the egg number. So I strongly encourage the back-to-back cycle. Less so with the duostem, even though there are some studies that show that it can improve outcomes. I think the back-to-back cycle is a bit more reliable in that regard. Let's see here. Hi, Kelsey. We've done an FVT to our GC, but no success. Is it time to try fresh? Kelsey's my friend. It's nice to see you this morning. Happy Sunday. I would say a fresh, using a fresh eggs is certainly an option. There are always some different options. There are always some different things that we can look at to say, well, this is what we've been doing these other cycles. So what can we do differently? What can we tweak? What can we change? And yours is a difficult situation there, Kelsey. So certainly something that we can talk about. And going back to the question of birth control, Anna Maria says, they gave my wife birth control when her cycle started, and she's supposed to stop on my cycle day 1, so we can do reciprocal with a fresh transfer. So there again, what we're doing with that is just trying to synchronize cycles so that one individual's cycle will coincide with another one, so that a fresh embryo transfer is something that will make sense. We've got just a few more minutes here before Facebook and Instagram will shut us down. And let's see if I can get in a good. Can I speak to a retroverted uterus, and if having one can affect getting pregnant? The answer to that is no, it should not. A retroverted uterus, some people have a uterus that sits forward, some people have a uterus that's in the mid position, and some sit backward, just like some people are right-handed and some people are left-handed. And so the retroverted uterus, it can change some of the sensation that you have in terms of kind of when you have a period. You may feel your cramps more in the back. Some people, when they're pregnant, will experience more what they call back labor, even though once the uterus grows with the pregnancy, it grows up and outside the pelvis anyway. And so retroverted, anteverted, mid position, antiflexed, retroflexed, all variations on whether the uterus sits forward or whether it sits back, but that shouldn't be an issue about getting pregnant. How, it looks like Maddie's asking, how does priming increase chances in IVF? Well, if we can give you some medication or something, some form of something that is going to improve the way your ovaries will make eggs, then that sounds like a good idea. And that's what priming is. Priming, we can use a bunch of different things. We can use growth hormone. We can use estrogen, progesterone. Sometimes we use low-dose naltrexone. We can certainly prime with the supplements on our list in order to just try to maximize the yield we get from your ovaries, both in terms of number and in terms of egg quality. Well, it looks like it's about a minute after the hour, and if I'm not mistaken, I think we probably started at about 2 minutes after, which means that Facebook, or rather I think Instagram, is probably going to shut us off in a moment here. Boy, it's sure nice to have a Sunday morning with you by the fireside, which you can't even see. Again, my apologies to the CNY Instagram side who weren't able to join us this morning. Maybe we'll be able to repost this on the Instagram. But thanks to everybody on Facebook and YouTube and LinkedIn and on my Instagram for being with us for Fink's Fertile Fireside on a Sunday morning. I'll see you Tuesday afternoon at 4 o'clock Mountain Time, 6 o'clock on the East Coast, where we'll have Fertility with Fink and Friends. Until then, have a great day. Sure is nice to be with you. Great to wake up with everybody. And my last sip of coffee to say, enjoy your Sunday. God bless and thanks for being here.